We're getting a steady stream of follow-up research, meaning real-world data on the use of these novel oral anticoagulants. And in this case, we're going to talk about Rivaroxaban, and it is major bleeding in a post-marketing assessment of 39,052 non-valvular AF patients on Rivaroxaban. And I am with Dr. Frank Peacock IV, who is a professor of emergency medicine at Baylor College of Medicine in Houston and the associate chief of emergency medicine research there. This is quite a big study. Why were you doing it in the first place?
So it's a PMSS study, which is post-marketing surveillance, which is required by the FDA and also provides real-world evidence, which is not the same as randomized controlled trials. Randomized controlled trials very limited in who's allowed in, and most people are excluded. Real world is your doctor puts you on the drug.
I mean, this ESC meeting, you could almost call it the real world meeting, because we are getting a lot of information on a lot of different agents. In this case, what did you learn?
So we looked at roughly 40,000 patients. 970 of them had some kind of bleeding, which makes it a pretty low bleeding rate. And of that, even remarkably fewer actually had a fatal event from it. So you end up with, this looks pretty safe. It's compared to, the data looks similar to that in the randomized controlled trials. The concern is that doctors would use this inappropriately and they'd have higher bleeding rates, and they actually have very low bleeding rates.
Now, in terms of comparing the major bleeding folks and those who are not major bleeders, any differences?
So yeah, the major bleeders have more comorbidities. So they have more heart failure and diabetes and all those sort of things, which is not unexpected. The score that predicts who should be on anticoagulants, the CHAD score, has all those things in it, and that's the sort of the prediction.
Hypertension was another one, if I remember right.
But those people are the very people who have the greatest risk of stroke. So they have a slightly increased risk of bleeding compared to somebody who's perfectly normal, but they also have a big increase in stroke. So the risk-benefit analysis comes to favor anticoagulating, even though they do have that small increase.
How was the bleeding ascertained?
So this whole thing was done looking at data from the Electronic Medical Records Department of Defense. And we used a Cunningham algorithm, which is, it's been validated. It's an algorithm that allows you to take a large administrative data set and figure out who bled from it. So it looks at things like blood transfusions and those kind of outcomes, as opposed to when you're doing a randomized controlled trial, you look over there and there's red on the floor, you know they're bleeding. So this is all paper investigation.
Because I know there's some concern about whether or not we're catching some of the people who are having bleeding, because they may have bleeding, but they just don't show up in some of the biomarker studies that people do.
Yeah, so I think that to say about the advantage of this Department of Defense data set is it's really an insurance data set. So if you're enrolled in a trial and you die, and you do it at a different hospital, and they don't have access to our hospital's database, you just disappear, but they don't know why. The advantage of using insurance company data, we know everybody went. It doesn't matter what hospital you went to, we got you. So we can say with pretty good confidence, you know, the bleeding risk here is 2.89 per 100 patient years. We think that's pretty darn accurate.
And so if you have patients who have more comorbidities, they may be the best in order of getting some major benefit out of the drug, but you do have to watch for the bleeding.
Yeah, I mean, it's an anticoagulant. It works. Anticoagulants, by definition, make you bleed. That's the risk you take. But when your risk of stroke is 20% and your risk of having a fatal bleeding event is less than 1%, this is sort of easy math.
So in bottom line, are you optimistic that what you're seeing here is what everyone is seeing across the country in terms of their data?
Yeah, I think you can look at this as a class. The NOACs are safer than Coumadin.
I think that's a good idea. I think that's a good message. From the ESC meeting, we have a variety of stories that we have all over the internet, and please, in both the CardioSource World News and the CardioSource World News Interventions, where I'm Executive Editor Rick McGuire.